We are going to start lymphoid structures in immunology. First, we are going to first immune system organs. There are two types, primary and secondary. The primary, in which the site of B-cell lymphocyte formation. And the secondary organs in which the T cell proliferate. In the primary organs, we include the bone marrow and the thymus. In the bone marrow, in which immune cell production and the B cell maturation. In thymus, it will be T cell maturation. In secondary organ, we have spleen, lymph nodes, tonsils, adenoids, appendix, bile patches, and this all immune cells to interact with antigens. And now, first, we are going to read about the detailed structure of lymph nodes. Before getting to it, we'll go with the diagram. I will make a simple diagram related to this. It's just like a kidney. You guys were thinking it was kidney, but it's a lymph node. It is also having an entrance pathway that is called efferent lymphatic. The efferent lymphatic have multiple routes. One lymph node can be having like 1, 2, 3, 4. It is having 4 routes like that. And for efferent, there is one or more only. Okay, not multiple. Now we talk about the inside structure. First, it is having the cortex. This part is cortex, in which the follicles are present. In that follicles, we are having one more type as a primary and secondary. The primary is just simple like that, and the secondary follicle having hollow-like depression like that. These, if you guys focus, that are secondary follicle. After the cortex, we have one part that is called paracortex. After the paracortex, we having medulla, and do this it's like that. Upper side look like the cord and inner side look like sinuses. So the medulla having two parts, medullary cord and medullary sinuses. This is the structure of lymph node. But how these all the structures are going to work? First, we have to talk about the follicles. The follicles are located in the outer cortex. As you know, it is a site of B cell localization and proliferation. The primary follicles are dense and quiescent, and secondary follicles are pale centrogerminal centers and are active. If we differentiate about primary and secondary follicles, the primary are inactive follicles and just a proper round shape in the histological structure, but the secondary follicles are active structures, and there are germinal centers, and they are having the central pale structures inside them. And what the follicles are doing, they are doing the proliferation and localization of B cells, and if helped by the nearby T helper cells, they can be bind and stimulate the proliferation of B cells. And follicle also having the follicular dendrite cells. Follicular dendrite cells, FDC, and these cells are the permanent cells of a lymph node. And there's a two type Also different types of dendrites. If you guys know the tissue dendrite, but they are totally different from tissue dendrite cells. Second, now we have to go paracortex. If you guys notice, the cortex we have in the follicle, the three primates can be, then it will move inside, then it will be paracortex. In paracortex, there will be T cells, and it's a region for cortex between the follicle and medulla, and contains high endothelial venules through which the T and B cells enter from the blood. It is a paracortex is a part between the follicle and medulla, and it's having two important structures. One is T cells, and second it is having endothelial venules. What is the function of that venules? They will give a path to the entrance nexus of the B cell and T cell to your bloodstream. Like if you guys know, the endothelial are also packed in the vessels, but in that endothelial venules, the endothelial cells are just like that. They're having a gap, so easily B and T cells will be move out of the lymph to the blood. Secondly, they are saying they are underdeveloped in the patient with a DiGeorge syndrome. DiGeorge syndrome having a 22q11.2 deletion syndrome. And in these patients, it is underdeveloped. And if you're having any chronic infection, if you guys having extreme severe immune response, then they could be biocortical hyperplasia, and due to it, you will find lymphadenopathy or enlarged lymph nodes. And secondly, guys, if you move into the lymph node, first you are getting the cortex, then paracortex, and after you are going towards medulla. In the medulla, there are the two-part medulla cords and the sinuses. Medullary cord, there are the packed lymphocytes and plasma cells. In sinuses, you will find reticular cells and macrophages. Medullary sinuses communicate with the afferent lymphatics, like exit pathway. Like these are afferent and these are efferent lymphatics. The afferent lymphatics, the lymph first go toward the follicles, follicle to paracortex, paracortex to medulla. Fine. And if you guys summarize the things, if you mention like follicle, and you have in paracortex, next part we are having medulla. In medulla we are having medullary cord and medullary sinus. In simple, you have to remember the cortex are affiliated with B cell. The paracortex is affiliated with the T cells. And second, endothelial venules. And medulla cord having plasma cells. And sinuses having macrophages. Don't forget these structures, okay? Follicles are affiliated with B cell, paracortex with T cell, medullary cord with plasma cell, and medullary sinuses, macrophages. This is all about the lymph node. The structure of lymph node and lymph node is one of the important is lymphoid organ that has many efferent and one and more efferent pathway. It's encapsulated with trabeculi, like that, trabeculites, and functions as non-specific filtration by macrophages, circulation of B and T cell, and immune response activation. Lymphatic drainage and association. It's a one of the important topic that always asks about the metastasis, enlargement of lymph node, lymphadenopathy, a lot of things. If any infection happening, which lymph node is included, it's a very important thing. But how you will be remember, just imagine your body and touch all the surfaces of your body when I will ask you. First, you have to touch your mandible bone and below insert Below the mandible, there will be submandibular or submental lymph nodes. If you come below this submandible, if you guys come below, there will be cervical area, and any lymph node present cervical area, it will be deep cervical lymph nodes. These are clavicle, and above the clavicle, there is a lymph node. It will be supraclavicular. This is the mediastinum, and any lymph node in the mediastinum will be mediastinal lymph node. There is a halo of the lungs, and that lymph node will become halo lymph nodes. That is the axilla. Axilla part of our arm. So any lymph node is there will be axillary lymph node. And after that, there will be trochlear part of the image. Here will be epitrochlear. But below the hilar, it will be very easy. If you guys know about the GIT, there are 3 sections according to embryonical, derivative, celiac, superior mesenteric, and inferior mesenteric. Same like that. For the GIT, in above we having the celiac lymph node, then superior mesenteric, then inferior mesenteric. But between the superior and inferior, there is the umbilical. So umbilical lymph node will be para-umbilical lymph nodes, and they were second name sister Mary Joseph node. There is the aorta. In near the aorta, there will be para-aortic lymph node, iliac. Outside the iliac, there will be external, inside the iliac, internal iliac lymph node. There will be inguinal ligament. In the inguinal upside, there will be superficial inguinal ligament. And there is in the leg, there is a popliteal fossa. There will be popliteal lymph node. It's so simple. First, you memorize the name of a lymph node. So it will be very easy to palpate. But all the things are related with their position. Okay, guys, like deep cervical related to head, neck, and oropharynx. Supraclavical is related to the hemothorax, abdomen, and pelvis. And the right side is right hemithorax. It's the important point for it is happening below the all of them. First, you can check the dark color. That dark red color. Already maintain the light lymphatic blood drains right side of body above the diaphragm into the junction of right subclavian internal jugular vein. Then the right side above the diaphragm. The right side above the diaphragm will be going to drain into right lymphatic duct, and it is junction of right subclavian and internal jugular vein. Okay, but over the other lymph node is going to drain in the thoracic duct. In the thoracic duct, and it's below the diaphragm and left thorax, upper limb, and it is going to in the junction of left subclavian and jugular veins. And there's one MCQ is important is there. If the rupture of thoracic duct is happening, what is going to happen to the chylothorax? The chylothorax. Rupture of thoracic duct going to, so chylothorax, the chylum in the lymph. The lymph will be in the thorax region. Like pneumothorax. Okay, the air in the thorax is same like that. And this is important, like the para-aortic, you can remember like the para means the pair of testes, ovaries, kidney, fallopian tube, and the fundus for uterus. And they also, one of their the important thing is that the celiac artery cover liver, stomach, spleen, pancreas, upper duodenum. Seeing the celiac lymph node is going to cover these organs. Same like superior mesenteric from lower abdomen to colon to splenic fracture. Inferior mesenteric colon to upper rectum. The same as the blood supplies there. And this is very important. The paraumbilical system Mary Joseph node is just an indication of gastric cancer. Okay. Please remember this by palpating your own lymph nodes by the sequence. First, they will be submandibular, then deep cervical, supraclavicular, mediastinal, hilar, axillary, epitopilar, from the abdomen, celiac, superior mesenteric, then paraumbilical, then inferior mesenteric, then para-aortic, external iliac, internal iliac, superficial inguinal, then popliteal. Now we are going to start about the spleen. Spleen is also a secondary organ of a lymphoid system in which there is a B and T cell proliferation, and it allows the cell to interact with the antigen. The basic and main fact is that it filters blood, not lymph. Before talking more about it, I want to simplify the diagram of a spleen, the structure of spleen. For example, that is spleen, and you know it filtered the blood, so there will be splenic artery taking the blood towards the spleen, and there will be a splenic vein that will take blood out from the spleen. There is two parts, white pulp and red pulp. White pulp and the red pulp. These pulps further having their own important structures. The white pulp having three important structures. First is follicles. Second, there is one structure, PLS, means very anterior lymphatic sheet, and on the margin there is one area called marginal zone. In a red pulp, the most important thing is sinusoids. Okay. The spleen having two parts, white and red pulp. The white are having three parts, follicles and the periarterial lymphatic sheath and marginal zone, and red pulp only having important part, that is sinusoids. Okay. In that white pulp, the follicle going to make the B cell, and the follicle having the mantle zone and germinal center as in the lymph node. That is mantle zone, and in the between it is the germinal zone. Then marginal zone and periarterial lymph node sheath is going to go to the T cells. And the sinusoid, in the red pulp, there is a sinusoids, reticular fibrous framework. And further, if we talk about the periarterial lymphatic sheath, that is part of the white pulp, it contains T cells and located within white pulp. The follicle contains a B cell and located in the white pulp. And the marginal zone, what is doing? It contains the macrophages and specialized B cells. It is site where the antigen-presenting cells capture the blood-borne antigen for the recognition by the lymphocytes and located between the red pulp and white pulp. If you guys know about the activation of the macrophages or opsonization of macrophages, then I will want to select, for example, this is a macrophage. On this macrophage, when antigen will be attached, for example, IgG, and after that IgG will be this cytokine and activate the complement system, and that complement system C3b will be attached to the microorganism and attract the macrophage. The macrophage will come and engulf all the microorganism. Okay, this one is a process. And how it is going to active all the process, how it adaptive immune response. These are dendritic cells that express the molecular dendritic cells that going to express the molecular histocompatibility 1, 2 and the B7, and these enter in lymph with antigens, and then entering to lymph node. And there's a many B and T cells waiting for antigen to express, and then that dendritic cell present the antigen to T cell, and then there will be APC antigen presenting cell in the lymph node that process through antigens, and there will be B cell that react to the antigen, and that is called the adaptive immune response. Now we are going to read about that where the location of spleen. The spleen is located in left upper quadrant of abdomen, and it's the anterior lateral to the left kidney, and it is protected by 9 to 11 ribs. And splenic dysfunction, like in some patients, spleen is not working, is mostly due to post-splenectomy or sickle cell disease, autosplenectomy. What is mean post-splenectomy? After the dysfunction of spleen or a removal of spleen due to different conditions, we are removing the spleen. The main condition is, if you guys know, hereditary spherocytosis. Hereditary spherocytosis. What is happening in that? There is abnormal shape of the RBC. The spleen is showing, and there is aneuploidy of doing the removal and destruction of the abnormal cells. So what is happening? There will be anemia in that patient. What we will do, splenectomy, remove the spleen, so there will be decrease the risk of anemia. And after that, there will be some signs and symptoms. Sickle cell disease, in what is going to happen in sickle cell, all the RBC are abnormal. The spleen is doing overwork. Due to doing overwork and removal and destruction of all lot of RBC, it will going to autosplenectomy, auto dysfunction. And by the way, there will decrease in IgM, decrease in complement activation, decrease in CT pre-opsonization, and there will be increase in susceptibility to encapsulating organism. I already told you there how encapsulating organism going to opsonize. First, there will be attachment of Ig immunoglobulins, IgG or IgM, and then there will be complement C3P, and then the microphage go to eat a phagocyte of that encapsulated organism. If spleen is going to dysfunction, if we are removing the splenectomy, then there is an increase in risk of encapsulated organism. What the encapsulated organism is most common as streptococci pneumonia. Streptococci pneumonia. And it causes death in more than 50% of cases, it's causing the death. And for that organism, we are doing vaccination of that patient that having splenic dysfunction, and this is most for the pneumonia, meningococci, Haemophilus influenza type B. And what is you will find in the body in the patient after post-splenectomy findings, like if a patient having no spleen, what type of findings you will be see? What are the findings in that patient? For instance, the whole jolly bodies. There is nuclear remnant, for example. That is the RBC. In that RBC, we find a small nucleus. Okay. A small nucleus. Like that, and these are whole jolly bodies. But if the spleen is working good, then automatically the spleen will destroy these cells. But now these cells are present in the peripheral plasmia, and you will see the whole jolly bodies. Thrombocytosis. Why thrombocytosis? Because in spleen there is a storation of circulation of platelets. If there is no, if we are having no spleen, then there will be no deposition of platelet, no the regulation. There will be no one who will do the regulation of the platelets. So there will be thrombocytosis. And lymphocytosis same. After the function, there will be destruction of the lymphocytes, and there will be storation of lymphocyte inside the spleen. If there is no spleen, then there will be also lymphocytosis. Okay, this is all about the spleen. And if you guys again divide it, have two type of pulp, white and red pulp. In the white pulp, there will be increase in the B cells in the follicles, and periarterial lymphatic sheath having the T cells, and also in the red blood there is sinusoids that having the macrophages, and also macrophages having their place. Like in liver, it is far cell. In the brain, things the microglia. In the bone is the osteoclast, etc. Now I'm going to start over the thymus. The thymus is the main part for the maturation of T cells, and it located anterior superior to the mediastinum, and it is the site of T cell differentiation and maturation, and it is encapsulated. The main question, the main fact about the thymus is that the thymus epithelium is derived from third pharyngeal pouch from the endoderm, but the thymic lymphocytes are going to derive from mesoderm. That is the amazing fact about the thymus. The thymus epithelium is derived from the endoderm, third pharyngeal pouch, and the thymic lymphocyte having mesodermal origin. It is also having some parts like cortex, then the medulla. In the cortex, then with the immature T cell, and medulla is appear as mature T cells. Like for example, that is the cortex, and this is the medulla. The cortex are immature T cells, and the medulla there is the mature T cells giving the pale look, and the hydrocorpus containing the epithelial reticular cells. The normal neonatal thymus is giving a cell shaped on the chest